Welcome to this video on the safe transfer of polytrauma patients to trauma centers, presented by emergency medicine consultant Dr. Abdul Hakam Ahmed. The decision to transfer a patient for definitive care is guided by identifying and suspecting specific injuries, anticipating their progression, and assessing whether your facility has the necessary resources to provide life-saving treatment. In this video, we will cover how to identify patients requiring transfer, define the responsibilities of both referring and receiving medical teams, recognize when stabilization is needed before transport, and understand how to maintain care during the transfer process. Consider this case. A 17-year-old male was transported to Al-Qara Hospital following an off-road vehicle accident. The patient presents with shallow breathing, an unstable pelvis, and a left thigh deformity. Vital signs are systolic blood pressure of 85 and heart rate of 120. While CT and ultrasound are available, the facility lacks specialized orthopedic or neurosurgical capabilities. Based on this scenario, what are the immediate management priorities for this patient, and does the facility have the resources to provide the required care? The primary principle of trauma management is to do no further harm. Indications for transfer include needing specialized care, like vascular surgery, lacking internal resources such as ICU or surgical support, needing definitive treatment, or managing patients with deteriorating physiology or severe head trauma. As the case progresses, the patient was intubated due to a drop in GCS, IV access was established, and a pelvic stabilizing device was placed. Following initial resuscitation, the patient's vitals improved. Imaging revealed a pelvic fracture, and secondary surveys identified the leg injury, for which blood products were ordered. When deciding on a transfer, you must ask, is it necessary? Why is it needed? How will it be conducted? When should it happen? And where is the patient being sent? Effective communication is critical. This includes sending a formal transfer record, coordinating with the transport team, notifying hospital administration, and ensuring the receiving trauma center is fully informed so their team is prepared upon arrival. With the patient stabilized, we must now consider what further diagnostic tests are truly necessary and what factors should determine our mode of transportation. A fast exam should be performed. If the patient is hemodynamically unstable, abdominal bleeding must be addressed before transport. However, if the patient is responsive, do not let further imaging delay an immediate transfer, especially if the facility cannot act on those scan results anyway. Remember that scans performed before transfer are often repeated at the trauma center. Avoiding unnecessary pre-transfer CTs reduces radiation exposure, minimizes costs, and prevents critical delays in getting the patient to definitive care. Treatment before transport should focus on the A, B, C, D, and E protocols, securing the airway, establishing proper IV access, performing necessary bedside investigations, controlling bleeding, and administering essential medications. Transportation should be via ground ambulance or air medical helicopter, determined by the distance to the facility. Importantly, a patient's insurance status must never influence the decision regarding the mode of transport. To conclude our case study, the patient received fluid and blood resuscitation, and although a fast exam showed a small amount of pelvic fluid, the patient remains hemodynamically stable and is ready for transfer. When contacting the receiving facility, providing clear information is vital. Use the ABC SBAR template to organize your report. Include the patient's history, survey findings, procedures performed, the patient's response, and any issues with hemodynamic stability. Remember to use the SBAR format: situation, background, assessment, and recommendation. Inadequate or inappropriate communication between referring and receiving providers can lead to the loss of critical information, which may negatively impact patient care. The referring doctor is responsible for treating immediate threats to life, initiating the transfer during resuscitation, selecting the appropriate transport mode, consulting with the receiving team, and stabilizing the patient's condition. Proper documentation must always accompany the patient. This includes a written record of their status and treatment, as well as any physical items like radiologic images on discs and relevant police reports or letters. The receiving doctor must be consulted to ensure their institution can accept the patient. They should assist in arranging the transport mode, and if their facility is unable to accept the patient, help find alternative placement. Looking at our case scenario, the patient was reevaluated upon arrival at the Level 1 Trauma Center. Clinical findings confirmed a splenic injury, a complex pelvic fracture, a small cerebral contusion, and a femur fracture, with the airway remaining secured. Let's review our objectives. Identifying patients requiring transfer, defining the roles of both medical teams, determining the need for stabilization prior to transfer, and recognizing the necessity of providing ongoing care during transport. Key learning points include knowing your institution's capabilities, establishing transfer agreements beforehand to avoid time delays, and treating life-threatening injuries to the best of your ability before moving the patient. Finally, match the transport mode to the patient's condition and availability. Ensure appropriate personnel are assigned, and never delay a necessary transfer for additional imaging or procedures that your facility cannot perform. Thank you for listening to this video on the safe transfer of trauma patients.